I will just be able, I'll read it and I will try to evoke the logical response from you. And I think there is nothing because you have already heard about these particular things. Now again the relevance to you. Why it is necessary that you are well versed with the national health programs of Government of India. We have common goals for public sector and private sector. Ultimately, you all are trying your level best for health for all, and you all are contributing to this standard declaration of Government of India, health for all, universal health coverage. It is a iceberg phenomenon, so guides public health response. What does that mean? Okay, it means that those who are reaching to you, those who are reaching to the hospitals, okay, they represent the tip of the iceberg. It simply means that large number of patients are still unattended, unseen, and they are there in the community. Over a period of time, again they will come up, they will become a part of tip of the iceberg and they will reach. So if you have seen the tip once, you must take it granted that yes, I need to go down, I need to investigate what is submerged, which is still not seen properly, and you must work hard to be on the lookout for this submerged portion of the iceberg, so that over a period of time you will be in a position to reduce the number of individuals who require the care at the tertiary health level. Okay. Clinicians and epidemiologists, they have a complementary role. What is clinician? Clinician is the one who sees the patient, who reports to him. Epidemiologist is going to be the one who is going to go into the community to be on the lookout for the potential patients. Okay, so the clinicians are also expected to contribute as epidemiologists, and they are the complementary role. You treat who reaches to you, at the same time be on the lookout who are in the incubation period or who are harboring the diseases, are yet to be detected by the health system, and if they are detected at that level, it is likely that the number of individuals who will require the care at the tertiary level over a period of time goes down. That is what it means. Reach almost 50%, your reach is almost 50%. So if national health programs are meant for 100% of the population, to 50% of the population, these program guidelines or program norms benefits are going to be reaching to the people through through doctors in the private sector. Training, technical and testing research support from clinicians is required. We do require a lot of support for training, technical support, testing facilities, and even for research from private sector. And scope for public private partnership, lot of scope for public private partnership, we have spoken about it. And effective advocacy, clinicians are in the position to offer effective advocacy to the patients, and usually the patient's response in terms of changing the behavior and adopting healthy lifestyles is better if clinicians perform this role very effectively. So why do we require national health programs? We have health infrastructure, we have hospitals, we have medical colleges, everything we have. But upon that, we still some of the issues, some of the problems, still they deserve the attention in the form of national health programs over and above whatever is provided to these diseases through the existing health infrastructure. So for which diseases we justify a separate national health program? It is in terms of morbidity and mortality. The diseases which have a very significantly higher level of morbidity and mortality, they deserve the attentions in the form of special national health programs over and above whatever are the services the hospitals are providing. Tuberculosis, the patient is definitely going to reach to you. Patient is going to reach to a clinician, hospital, private sector, wherever. Whoever is going to suffer is definitely going to reach to a doctor for taking the treatment. Okay, but is it enough that those who are reaching to you for treatment purpose, you look after them, you cure them? Is it going to resolve the problem of transmission of tuberculosis in the community? No. Many things you will have to undertake outside the four walls of the hospital in order to reduce the transmission. A case of malaria, you will manage a case of, you will diagnose, you will manage a case of malaria. But transmission of malaria, you are not in a position to influence transmission if you are going to limit your services only diagnosing and managing a case of malaria. Okay. Same thing holds for disability. A large disability, large number of people becoming disabled, poliomyelitis, leprosy, vitamin A deficiency associated blindness. Okay, so these, if the proportion is too high, then these issues, these diseases deserve the attention in the form of national health programs over and above what you are providing. Socio-economic consequences. Now, if you look at the situation of malaria in terms of number of man working days lost, if you look into the situation of tuberculosis in terms of man working days lost, HIV/AIDS man working days loss, then it incurs a lot of socio-economic consequences to the government. Okay, a breadwinner in the family, if he loses the job, if he succumbs to the illness, if he is going to be on the bed for extended period of time, what happens to that individual family as far as earning the livelihood is concerned? Same thing holds true when it is going to happen in case of millions of people at country level. So if this is going to be the situation, then you deserve attention in the form of national health programs. Availability of cost effective intervention measures. See, this is how we justify the existence of universal immunization program. You have the diseases on one side, you have the effective vaccines also on one side, but we came across the situation that these effective vaccines are not reaching to the potential beneficiaries for these vaccinations. That means you have to have something to make it possible that that the problems and solutions are coming together and the problem is resolved. Okay, so for that, universal immunization concentrated more and more on improving the coverage of the children with immunization. Vaccines are available, the beneficiaries are there, the need is there, solution is there, but these two ends were not meeting, and that was the purpose. That was the purpose of universal immunization program. Then technical and operational feasibility, yes, if there is a technical and operational feasibility to implement the program in the form of national health programs is well and good. Now, when diabetes control program came into existence in the year 1987, the government came to know the situation that the doctors who are working at the primary health center level are not capable of diagnosing, interpreting the result, and based on the findings of the investigations, they were not in a position to treat the patients. Okay, so that technical know-how was not existing then. There were some, when revised national tuberculosis control program came into existence, the government said that yes, at each primary health center initially we will make the facility for sputum examination will be available. But then they came to know that yes, it is not possible because primary health center has no lab technician. So it is not going to be possible that all the primary health centers are going to be equipped immediately with those many lab technicians. Okay, so take into account what is available, take into account what is the manpower at my disposal, take into account to whom I can entrust the responsibility related to the implementation of the new program, or if something new we propose to do, and then talk about the national health program. And necessity of integrated approach. You need an integrated approach. Say if you say malaria, you need the hospital services, you need the pesticide services, you need the environmental sanitary conditions, you need to develop the capacity of all healthcare force in the community. Now all these things are beyond the capacity of the hospital doctors. So these issues, they have to be looked into by the different body in different terms and conditions, for which you justify the implementation of a separate national health program. Now, any national health program you read, any national health program you read in the books, more or less the strategies are going to be on these lines. Now, it is not that each national health program will have these strategies. Depending upon the situation, depending upon the epidemiological characteristics of that individual disease, you will have to decide what applies to this particular problem and what does not apply. Okay, but more or less it revolves around this: reduce the morbidity, mortality, disability associated with the problem. Definitely, if you are going to assess, if you are going to address the issue of morbidity, mortality, disability, you must have in national health policy also, your priority is going to be to reduce that, interrupt the transmission of the disease wherever possible. Disease surveillance: today our problem is that our disease surveillance is very weak. Okay, we really do not know how much is my disease load, and unless and until you are aware about the disease load which you need to be managed, you are not in a position to plan for it. Okay, and that is the major issue. Maybe in a city of Mumbai the situation is better, but if you go down to the district level hospital, the things are really very bad. Enhance the host resistance. Now ultimately all the time it may not be possible that you will do whatever needs to be done in a short period of time, because it is again going to incur a lot of money. You need large resources in terms of man, money, material, etc. Okay, so the best option is wherever possible enhance the host resistance. What we do by immunizing the people. Okay, it is not possible that we want to get rid of all diarrheal diseases by improving the water supply and sanitary conditions of this country. It is beyond the scope in a shorter period of time. It is better that wherever the vaccines are available, we will promote the vaccination coverage to address that particular issue, because that becomes the cost effective way. Reduce the socio-economic consequences associated with the problem. So whatever are the socio-economic consequences associated with the problem, maybe it is a disability, or maybe it is a loss of income, etc. How best these issues also can be. Poliomyelitis, how best you can reduce the disability. Leprosy, how best you can reduce the disability so that the earning capacity of the person is retained. Development of appropriate infrastructure to deliver the services all the time at all the places for all the benefits. Capacity building of healthcare force, create demand for services. Always remember that this is a major issue, and you have to incorporate it as a part of national health programs. Immunization, yes, today you will do the immunization, but subsequently people, you will expect the people to come forward on their own to keep up their immunization status. That vaccine hesitancy what we are witnessing today for COVID-19 vaccine, that should not be the scenario. You immunize simultaneously, take care that this demand for immunization is going to be retained, enhanced, and subsequently people will come forward on their own to get immunized. Improve the accessibility to basic services. That accessibility, affordability. Accessibility here is a functional accessibility. It should not be that the hospital is situated next door, but hardly any time it is seen open. That should not be the scenario. When we say accessibility, it is a functional accessibility. And the socio-economic development. Ultimately, whatever you are going to do, whatever amount of money you are going to invest in the health sector, the benefits will be evaluated in terms of number of days saved, disability adjusted life years saved, improved. So identify one composite indicator which will make it possible to understand even to the health professional as well as other investors, to find out how much is the investment, how much is the direct benefit through whatever unit of money they are spending on it. Okay, so when you say national health programs, some important national health programs I will show. For example, family welfare. Now this family welfare has always been a priority of us since 1952. India is the first country in the world who introduced National Family Planning Program in 1952, and it is still a priority. That means still lot many things are to be done to reduce the growth of the population. Today we are at the level of very rapid growth of the populations. We have not come down to the slowing the growth of population development. Okay, once upon a time we were in the phase of population explosion. Today slightly lesser, that is very rapid growth, 1.5%. Then subsequently All India Hospital Postpartum Program to promote family planning was introduced in 1970. Child Survival Safe Motherhood Program 1992. then reproductive and RCH program 1 in 1997, and today you have what is known as RCH2 2004. Okay. Then for VPDs, VPD stands for vaccine preventable diseases. The expanded program on immunization came into existence in 1978, which was upgraded as UIP, Universal Immunization Program. Sorry, it is 1985 and it is not 95. Okay. Tuberculosis, initially National Tuberculosis Control Program in 1962. Remember that tuberculosis control program 62 means almost 60 years are over and we are still struggling with tuberculosis. RNTCP 1993, and today what you have since 2017 is National TB Elimination Program. HIV AIDS, yes, National AIDS Control Program 1, 87, National AIDS Control Organization in 1992, NACP 2 99, NACP 3 2007, NACP 4 2012, NACP 5 is on the way. So as the disease pattern has changed, as the epidemiological changes are seen, as the priorities have changed, the strategies in individual phase 1, 2, 3, 4 have changed. Malaria, lot many things. National Malaria Control 1953 onwards. National Malaria Elimination, Eradication. This initial E was eradication. So control was converted into eradication. We thought of extinction of malaria in 1958, but unfortunately we could not. Then National Urban Malaria Scheme came into existence. Modified Plan of Operation, Malaria Action Program, Enhanced Malaria Control Program, National Anti-Malaria Program, Vector-Borne Diseases Control Program since 2004. The same issue is addressed in different names, just and with the new name, new strategies got introduced, new guidelines came. Okay, and but we are still, even today we are struggling with this problem. Today what we have for malaria is National Vector-Borne Diseases Control Program, which looks after 5 diseases, 5 vector-borne diseases. So for filaria, National Filaria Control Program since 1955, but this program today has become a part of National Vector-Borne Disease Control Program. Leprosy, yes, National Leprosy Control, National Leprosy Elimination, Modified Leprosy Elimination Campaign, Special Action Projects for Elimination of Leprosy, etc. Today we have what is known as Leprosy Eradication Program. Okay, so this is the historical background. So many programs are there, and over a period of time so many phases were introduced, and we are still struggling with all these problems. Guinea worm is one which is already eradicated, Guinea worm eradication program 1983, and this is the one disease which got eradicated in the shortest possible time. The credit goes to the epidemiological characteristics of this disease, which make it possible to eradicate than control. Okay, eradication strategies were easier than control strategies. Then disease surveillance, IDSP, Integrated Disease Surveillance Project, which is going on since 2004, it is still valid, and we all are reporting to IDSP. As far as non-communicable diseases are concerned, we have for blindness National Program for Control of Visual Impairment and Blindness existing since 1976. The program also is changed. The name of the program also got changed over a period of time. As far as mental health is concerned, National Mental Health Program since 1982. It was not since for extended period of time, and it has become a priority program today. Cancer, National Cancer Control Program since 1985. Today we have what is known as NPCDCS, National Program for Cancer, Diabetes, Coronary Vascular Diseases and Stroke since 2010. Diabetes, National Diabetes Control Program 1987, but it is no more existing. It has become a part of NPCDCS. There were n number of national programs in nutrition. Integrated Child Development Services since 1975, Midday Meal Program 1961, National Nutritional Anemia Prophylaxis 1970, National Program for Prophylaxis Against Blindness in Children caused due to vitamin A deficiency, National Goiter Control Program got converted into an Iodine Deficiency Disorders Control Program. National Iodine Deficiency Disorders Control Program. What I am showing through all this, that we have a big list, and also the program existing for decades together. In spite of that, still not many things are yet to be achieved in the same portfolios, and the programs are continuing. You can imagine what must be the workload, you can imagine what must be the challenges, and you can imagine what amount of money must be going into the implementation of these programs. Other programs are Integrated Rural Development Program, IRDP, that cross-sectoral approach what I am talking about. Accelerated Rural Water Supply Program, Central Rural Sanitation Program, Accelerated Urban Water Supply Program, National Slum Development, Minimum Needs, 20-point program. Okay. So lot many. Even today, if you go through the books, National Health Program, there is a separate book on National Health Programs. Okay, the list is still bigger. Okay. Now, what are the differences in old and new approach in family welfare program? What was the old approach? What is the new approach? Even if you get sensitized to this much, more than enough, rather than going into the details of individual program. So primary goal once upon a time was meet the norms of two children. Hum do, hamare do. That was the primary goal in the past. Today, it still encourages the smaller family, but helps the client to meet their own health and family planning goals. Okay, so you are sensitive to the demands of the individual couple rather than insisting only on two child norm. If they say no, fine. If they say only one, fine. If they say two, that is also fine. So you must take into account the desire and according national priorities, desire of the individual couple, and then see how best you can support that particular family. Priority services in the past were family planning, and family planning was equated with tubectomy. Today, it is the full range of RCS services. So, family planning, we do not have National Family Welfare Program as on today. It has become a part of RCH or National Health Mission. Okay. So in the past, performance was based on how many number of cases you have completed. Today, it is the quality, care, satisfaction, and coverage measures. So more broader perspective. Management initially was top down. You used to get the targets from the top authorities, from center to the state, state to the district, district to the primary health centers, etc. Today it is decentralized. That means we promote that the individual primary health center will identify the targets in the family planning for them to be achieved in 1 year, and the combination of these action plans developed at each primary health center will be forwarded to the districts, and then district will identify its target based on the targets received from the individual primary health center. So the decentralized approach, rather than getting the targets from higher authorities, you decide your own targets and work accordingly. Management approach previously was target driven, today it is client need based. Attitude was to motivate and persuade, today it is gender sensitive, listen, access the need, and inform, give, provide inform advice. Accountability initially was to the government, today it is to the client and community. Okay, so this is a paradigm shift in the family welfare program. So when we talk about family welfare program, which is existing for more than 70 years now, over a period of time, how it is transformed. Then today what we have is RCH2. Okay, RCH2 is also a part of National Health Mission, and this RCH2, even though it is written as 2004 to 2009, it still continues, and the components which are included in this RCH are population stabilization, always top one, that is reduced population growth. Maternal health, newborn care, child health, adolescent health, RTI, reproductive tract infection, sexually transmitted infection treatment and control, urban health, tribal health, and other priority areas are strengthening the services at all levels, infrastructure development, supply of drugs and equipments. Okay, so RCH program, when you say RCH, R stands for reproductive child health, it includes all these 7, 8, 9 elements. Then National Tuberculosis Elimination Program. Incidence of less than one case of infectious tuberculosis per million population. So how much is that today? When your goal is set to reduce to less than 1 per million, okay, how much is that today? It is around 215, exact number 215, 17 per 1 lakh. That means 2170 per million. Okay, and that you want to reduce to less than 1 million. So you can imagine how much ambitious goal you have already set for yourself to achieve. So vision is TB free India with zero deaths, disease and poverty due to tuberculosis. Goal is to achieve a rapid decline in burden of tuberculosis, morbidity, mortality while working towards elimination of TB in India by 2025. So from time to time we have set different targets, we have identified different priorities, etc., etc. TB still continues. Now whatever we are talking about is to be achieved by 2025. Let's hope that at least to some extent you are successful in achieving the pre-decided targets, and let's see what happens. Key priorities in National AIDS control program. So I have already told you that today we have what is known as NACP 4. NACP 5 is on the way. Okay, but NACP 4, the priorities are preventing new infections, prevention of parent to child transmission, focusing on IEC strategies and behavior change communication, comprehensive care support and treatment, reduce stigma and discrimination associated with HIV/AIDS, decentralization of services, effective use of strategic information management systems at all levels, building capacity of NGOs and civil society partners, integrating HIV services with health systems in a phased manner, and mainstreaming with other departments other than health departments. Okay, so NACP 4 speaks about all these things. Then you have what is known as integrated disease surveillance project. The important things which are going on, I am just highlighting all these things because it is beyond the scope of describing individual program in detail. So here the project objective is to establish a decentralized state-based system of surveillance and to improve the efficiency of the existing surveillance activities. Our surveillance is very good. Surveillance is collecting the relevant information for taking appropriate action. Okay, so when there is no action, we call it as survey. So we don't talk about survey, we talk about surveillance because we want to collect the information to take action upon that. Okay, so this surveillance needs to be strengthened. So the diseases which are under surveillance today, for regular surveillance we have for vector-borne diseases which includes malaria, water-borne diseases, acute diarrheal disease, typhoid, respiratory disease, tuberculosis, vaccine preventable diseases, measles, diarrheal disease problem under eradication, polio. Other conditions to be reported are road traffic accidents, international commitment for plague, unusual clinical syndrome, that is meningoencephalitis, respiratory distress, hemorrhagic fevers, and other undiagnosed conditions. So these are the problems, diseases which you must report to the health system irrespective of the fact whether you are working in public or private sector. Okay, even if you are working in private sector, you need to report it. Then we have a sentinel surveillance. Sentinel means center based, that selected centers only will report this. That is sentinel surveillance. So we have sentinel surveillance for STDs, blood-borne diseases, for HIV, hepatitis B and hepatitis C virus infection. Other conditions which are kept under sentinel surveillance are water quality, outdoor air quality in large urban areas, And regular periodic services are going on for certain non-communicable diseases, that is anthropometry, physical activity, blood pressure, tobacco, nutrition, blindness, and any other unusual health conditions of emergency which may come up from time to time. Okay, today you must have seen NCD corners in big hospitals. Now these NCD corners also are contributing a significant data to IDSP. Okay, then you have what is known as National Vector-Borne Diseases Control Program, NVBDCP, National Vector-Borne Diseases Control Program. So here the strategies. Now this National Vector-Borne Diseases Control Program covers 5 diseases: malaria, filaria, dengue, Japanese encephalitis, and Kala Azar. These are the 5 conditions which are covered under NVBDCP, because all of them, they are vector borne. Okay, so strategies are going to be more or less the same. So here the priorities are disease management, management of insecticide resistance, legislative measures like building bylaws. You need building bylaws because lot of malaria cases today you are getting because of lot of construction activity which are going on in the city areas. So wherever a construction activity is going on, government has already identified certain guidelines in order to prevent the likely breeding in these places. Okay, so that goes in building bylaws. Then involvement of NGO sector and private sector for reporting as well as management. Quality assurance on lab diagnosis for all these diseases. Long lasting insecticide treated nets. Insecticide mosquito nets are used to prevent man vector contact, and if they are treated with insecticides, that means if the net is treated with insecticide, they will have additional benefit, because when you say mosquito net, maybe that it is used, or even if it is used, then it is going to be torn, it is not appropriately used, still the purpose of avoiding man vector contact is not made. But if it is treated, then you have two things: one, prevent the man vector contact, and if at all that is not sufficient, and if the net is insecticide treated, it is likely that this insecticide will kill the mosquito. So it is double: contact poison as well as prevention of contact. Improved efficiency and quality of services at primary, secondary, tertiary levels, environmental management, monitoring and evaluation, collaboration with National Institute of Malaria Research and Medical College, intersectoral coverage for early diagnosis, prompt treatment, integrated vector control, behavior change communication activities for social mobilization. So lot many things. Now these things, if you see all these list, except management and investigation, rest of the things you will find beyond the limit of the hospital services. And if these things are required for preventing transmission of these vector borne diseases, you deserve attention in the form of national health program. Okay, you have a national program for control of blindness existing since 1976. Current objectives: reduce prevalence to less than 0.3% of blindness, establish effective infrastructure for that. Objectives: established eye care facilities for every 5 lakh population, which is the norm of the government. 5 lakhs means 5 rural hospitals. So government is now appointing one ophthalmologist for 5 lakhs of population. We do not have the enough number of ophthalmologists even to meet these norms, but the target set is that you have to have at least one ophthalmologist covering 5 hospitals. So once in a week he attends every hospital. Develop human resources for eye care services at all levels, CSCs, PSCs. What we have is refractionist. Government proposes to appoint refractionist for early identification of visual impairments, maybe because of cataract or due to some other ophthalmic problems. And this refractionist, they visit all the PSCs on some fixed days, and they identify the cases. Improve the quality of service delivery and to secure participation of civil society and primary and the private sector. Then you have what is known as National Iodine Deficiency Disorders Control Program. 6.1 crore people suffering from endemic goiter, 88 lakhs are mentally handicapped. Even, that means even today the number is huge. Objective is conduct a survey to identify the magnitude. From time to time. Government recommends that yes, this population based survey needs to be undertaken once in 5 years. Universal supply of iodized salt. Okay. Information, education, communication, monitoring quality of iodized salt. See, remember that this also becomes very important. The iodized salt will have 30 ppm of iodine level at the point of manufacturing, and it has to be at least 15 ppm when it is at the consumption point. And many times, because of improper storage, this iodine level comes down. So even if large number of people are saying that yes, we are using iodized Tata Namak, how much is the iodine left out at the point of consumption, we really do not know. Okay, so that needs to be addressed over here. And resurvey every 5 years to assess the impact of the program. The national mental health prevalence 65 per 1000 population, 2% suffer from seriously incapacitating mental disorders at any point of time. Here our objectives are ensure availability and accessibility of minimum mental health care to most vulnerable and underprivileged population, encourage application of mental health knowledge in general health care, to improve community participation in the mental health services development, and to stimulate efforts towards self-help in the community. Okay. So then NPCDs, yes. NPCDs is for prevention of cancer, diabetes, CVS and stroke. Health promotion through behavior change, prevention and early detection of non-communicable diseases, building capacity at various levels of healthcare facilities for prevention, early diagnosis, treatment and rehabilitation in respect of non-communicable diseases, supporting development of database for NCDs through regular surveillance, monitoring risk factors, morbidity, mortality associated with NCDs, and establish and develop capacity for palliative and rehabilitative care. Then you have what is known as NRHM, National Rural Health Mission. Your initiatives with main focus on rural poor population with holistic health package delivery approach with strong monitoring mechanism. NRHM stands for National Rural Health Mission, and this National Rural Health Mission is this new things for deserving with comprehensive approach and good monitoring. Okay. So this is National Health Mission, safeguard the health, strengthen the public health systems, build environment of trust between people and providers of health services, empower community to become active participants in the process of attainment of highest possible level of health, institutionalize transparency and accountability in all processes and mechanisms, and improve efficiency to optimize the use of available resources. See, remember that. So this is again the target sets in this one. As your understanding related to individual health issue improves, and as your look, whether it is going to be the approach of patient, whether it is going to be a patient centered approach or whether it is going to be a community control centered approach, okay, will make you wise to decide what should go in. That is what it means. So when you read it, it sounds too many things and too big things, but if you visualize the individual problem, you will all these things are done in a very logical fashion to address the issue comprehensively. So what common problems we do come across? Our common problems as far as national health programs are concerned is the lack of political and administrative commitment equally to all. There are certain programs where this is very easily visible. For example, HIV AIDS, for example, tuberculosis, for example, family planning, but it is not equally seen in other programs. Financial constraints, inappropriate material management, problems in human resource management, no emphasis on quality aspects, weak supervision, and no accountability. So these are the current problems we have identified in implementation of national health programs. Okay. So I think we will stop. This is not important. Thank you. So if you have any queries, both the topics are too big, too vast to be covered.